Hi friends, welcome to PharmaGrid. So today we are going to learn about fluids and electrolytes. So in this session, we will discuss more about the functions as well as the regulation mechanisms of fluids, especially water, and the major electrolytes such as sodium, potassium, then calcium, magnesium, phosphate, etc. Also, we will discuss the disorders associated with the fluid and electrolyte imbalance. Okay, so first we will see the composition of body fluids. We know that water is the most abundant constituent in the human body, comprising approximately 50% of body weight in women and 60% in men. Okay, and this total body water is distributed into two major compartments, that is the extracellular fluid and the intracellular fluid. 55 to 75 percentage is intracellular fluid, which is denoted as ICF, and 25 to 45 percentage is extracellular, which is denoted as ECF. And then the ECF, that is the extracellular fluid, is further subdivided into intravascular fluid, that is the plasma water, and the extravascular, which is known as the interstitial spaces, in a ratio of 1:3. Okay, so this is more summarized from this diagram, or this is more clearly depicted in this diagram. Okay, so the total body water out of this 42 liter in a normal adult man, 60% of the body weight in a 70 kilogram person. Okay, so out of this, it is mainly divided into two compartments. That is the extracellular fluid, which is further subdivided into interstitial fluid and plasma, and then the intracellular fluid. The intracellular fluid constitutes about 2/3 portion of the total body water, and the extracellular fluid, the remaining portion, or else we can say it covers about 1/3 portion of the total body water. The solute or particle concentration of a fluid is known as its osmolality, which is expressed as milliosmoles per kilogram of water. Okay, so osmolality means it is nothing but the solute or particle concentration of a fluid. Water easily diffuses across most cell membranes to achieve osmotic equilibrium. So when this osmotic equilibrium will be achieved? When the extracellular fluid osmolality becomes equal to intracellular fluid osmolality. Notably, the extracellular and intracellular solute compositions differ considerably owing to the activity of various transporters, channels, and ATP-driven membrane pumps. Solutes that are restricted to the extracellular fluid or the intracellular fluid determine the tonicity or effective osmolality of that compartment. Okay, so the solutes has very importance in maintaining the tonicity or the effective osmolality of the particular compartment. Certain solutes, particularly urea, do not contribute to water shifts across most membranes and are thus known as ineffective osmoles. And these are the main electrolytes in the body fluid, which include sodium, chlorine, magnesium, calcium, and potassium. And their major functions include balancing fluids in your body, then maintain blood's proper pH, and carry electrical signals from nerves to muscles. So in this slide, I have mentioned the electrolytes and their functions. Sodium. It is essential for fluid balance, muscle contraction, nerve signaling. Potassium regulates the blood pressure levels, heart contractions, and muscle function. Magnesium is required for the muscle or nerve function, heart rhythm, and the growth of bones and teeth. Calcium is essential for muscle contraction, nerve signaling, blood clotting, as well as the proper growth of bones and teeth. Then chloride is very essential or very needed for fluid balance, proper maintenance of blood pH, then stomach acid production. Phosphate is required for the growth of teeth and bones, then nerve and muscle function. Bicarbonate, its main function in maintaining the acid-base balance. So as I have already discussed, the total body water is further subdivided into intracellular fluid and the extracellular fluid. This intracellular fluid constitutes a 2/3 portion and extracellular fluid covers over 1/3 portion of the total body water. And this extracellular fluid is further subdivided into intravascular and interstitial fluid. Okay, now moving on to the solute concentration. The major extracellular fluid particles are sodium and its accompanying anions chloride and bicarbonate. Okay, so this is the extracellular fluid, and the extracellular fluid, the major cation is sodium and the major anion is chlorine. Okay, cation means positively charged ions are known as cations and negatively charged ions are known as anions. Okay, so sodium is the major extracellular cation and chlorine is the major extracellular anion. Whereas potassium and organic phosphate esters, which includes ATP, creatine phosphate, and phospholipids, are the predominant intracellular fluid osmoles. Okay, so here you can see the intracellular fluid. Here, the major intracellular cation is potassium and the anion is phosphate. Okay, so the major intracellular cation is potassium. Now, what are fluid and electrolyte imbalances? A disturbance of body water balance in which more fluid is lost from the body than is absorbed results in reduction in circulating blood volume and in dehydration of the tissues. In contrast, the rapid ingestion of large quantities of water can lead to overhydration or water intoxication. Okay, so the two main imbalances or two main disorders associated with the fluid in the sense water is known as dehydration or excess water loss or hypovolemia, and overhydration. Overhydration means excess water intake or water intoxication. Electrolytes are electrically charged minerals dissolved within the body fluids that, when exchanged properly in and out of the cells, preserve the body's nerve and muscle functions. There are different types of electrolytes. Sodium, potassium, and chloride play a significant role in cell homeostasis. Cell homeostasis means it is a self-regulating process of the body to adjust to conditions that are optimal for survival, along with calcium, magnesium, phosphate, and bicarbonate. So, what do you mean by electrolyte imbalances? This refers to variations of electrolyte levels within body fluids occur commonly as a result of loss of electrolytes, shifts of certain electrolytes, or relative changes in concentrations caused by loss of water. So common electrolyte imbalances include hyponatremia, hypokalemia, hyperkalemia, hypocalcemia, hypochloremia, and hypophosphatemia. Okay, so this is about the electrolyte imbalances. If there is a loss of electrolytes, okay, if there is a loss of electrolytes, mainly hyponatremia, hypokalemia, hypophosphatemia, these type of disorders can occur. And if there is an excess of electrolytes, okay, excess of electrolytes will lead to hypernatremia, hyperkalemia, then hypercalcemia like disorders. Then acid-base imbalances. They are mainly categorized as acidosis and alkalosis, occur as a result of the addition of acid and depletion of alkali reserve, or the loss of acid with a relative increase in alkali reserve. So here you can see the electrolyte concentrations in the extracellular fluid and the intracellular fluid. From this it is clear that sodium, okay, sodium is present mainly in the extracellular fluid, which is the extracellular cation. Okay, sodium is the major extracellular cation, and potassium higher concentration is present in the intracellular fluid, and potassium is the intracellular cation. It is a major intracellular cation. Then here you can see the normal daily requirements of major electrolytes, that is sodium 50 to 100 milliequivalent per day, potassium 0.5 to 1.5 milliequivalent per kilogram, phosphorus 30 to 24 millimole, magnesium 24 to 32 milliequivalent, calcium 10 to 20 milliequivalent, chloride 80 to 120 milliequivalent, and acetate 80 to 120 milliequivalent. Okay, so you can refer this slide in order to learn the electrolyte concentrations in the ECF and the ICF, as well as the normal daily requirements of these major electrolytes. Sodium and water balance. Sodium and water metabolism are closely interrelated both physiologically and clinically, and play a major role in determining the osmolality of serum. Total body water is regulated by the renal action of ADH. ADH means antidiuretic hormone. Then the RAS system, the renin angiotensin aldosterone system, noradrenaline bar norepinephrine, and by thirst, which is stimulated by rising plasma osmolality. Okay, so the total body water is regulation by the mechanisms include antidiuretic hormone, then the RAS system, noradrenaline bar norepinephrine, and by thirst. In general, water permeates freely between the ICF and ECF. Cell walls function as semi-permeable membranes with water movement from one compartment to the other being controlled by the osmotic pressure. Water moves into the compartment with the higher osmotic concentration. Higher osmotic concentration in the sense osmolality is determined by the solute concentration. Okay, so water normally moves from a region of higher concentration to lower concentration. But if we say in terms of osmolality, water will move into a compartment with a higher osmotic concentration. Higher osmotic concentration means there will be higher solute concentration and less water concentration. So water will move into a region of higher osmotic concentration where there is less water. Okay, where there is less water. The osmotic content of the two compartments is generally the same, that is they are isotonic, which ensures normal cell membrane integrity and cellular processes. However, the kidneys are an exception to this rule. The osmolality of the extracellular fluid is largely determined by sodium and its associated anions, chloride and bicarbonate. Protein, especially albumin, makes only a small, that is 0.5% contribution to the osmolality of the extracellular fluid, but is a major factor in determining water distribution between the two compartments. The contribution of proteins to the osmotic pressure of serum is known as the colloid osmotic pressure or oncotic pressure. The major contributor to the osmolality of the intracellular fluid is potassium because potassium is the major intracellular fluid cation. The amount of water taken in and lost by the body depends on intake, diet, activity and the environment. Over time, the intake of water is normally equal to that lost. The minimum daily intake necessary to maintain this balance is approximately 1100 ml. Of this, 500 ml is required for normal excretion of waste products in urine, while the remaining volume is lost via the skin in sweat, via the lungs in expired air and in feces. The kidneys regulate water balance, water being filtered, then reabsorbed in variable amounts depending primarily on the level of ADH. Here you can see the regulation of effective circulating volume. What all are the factors that affect the regulation of circulating volume? Kidney. In the kidney, that RAS system, that is the renin-angiotensin-aldosterone system. Then extra-renal involves the sympathetic nervous system, mainly the epinephrine and norepinephrine and atrial natriuretic peptide. Then regulation of plasma osmolality by vasopressin release, thirst and osmoreceptor sensitivity. Water and extracellular fluid osmolality. If the body water content changes independent of the amount of solute, osmolality will be altered. So the normal range of osmolality is 282 to 295 millimole per kilogram of water. A loss of water from the extracellular fluid will increase its osmolality. Increase in the osmolality in the sense, if there is a loss of water, their solute concentration will increase. Osmolality represents the solute concentration, okay, solute concentration of the fluid. So if there is loss of water from the extracellular fluid, this will increase the osmolality of the extracellular fluid and result in the movement of water from the intracellular fluid to the extracellular fluid. So this increase in extracellular fluid osmolality will stimulate the hypothalamic thirst centers to promote a desire to drink, while also stimulating the release of vasopressin or ADH. Okay, so this increase in osmolality will stimulate the hypothalamic thirst centers. Okay, so there will be a desire to drink. Also, it will stimulate the release of vasopressin. This ADH increases the permeability of the renal collecting ducts to water and promotes water reabsorption with consequent concentration of urine. If the osmolality of the ECF falls, there is no desire to drink and no secretion of ADH. Consequently, a dilute urine is produced, which helps restore extracellular fluid osmolality to normal. The secretion of ADH is also stimulated by angiotensin II, arterial and venous baroreceptors, volume receptors, stress, including pain, exercise and drugs such as morphine, nicotine, tolbutamide, carbamazepine and vincristine. If blood volume decreases by more than 10%, the hypovolemia stimulates ADH release and overrides control based on osmolality. Okay, so now we will see the disorders associated with the fluid balance. First one is water depletion or dehydration, or we can say hypovolemia. So excessive loss of water through the kidney is unusual except in diabetes insipidus or following the overuse of diuretics. Deprivation of water, a lack of thirst caused by toxemia, and the inability to drink water as in esophageal obstruction are examples of dehydration from inadequate water intake. The most common cause of dehydration is when excessive fluid is lost. Diarrhea is the most common reason for excessive fluid loss, although vomiting, polyuria, and the loss of fluid from extensive skin wounds or by copious sweating may be important. Patients with fever will lose water through the skin and ventilated patients will lose it through the lungs. Water loss is usually compensated for if the thirst mechanism is intact or can be responded to, but this may not occur in patients who are unconscious and those patients having swallowing difficulties or are disabled. Severe water depletion may induce cerebral dehydration, causing confusion, fits, coma, and circulatory failure. So there are mainly two major causes of dehydration. Dehydration in the sense decrease in free water, which includes the inadequate water intake and excessive fluid loss. So as a treatment option, the underlying cause for the water depletion should be identified and treated. Replacement water should be given orally where possible or by nasogastric tube intravenously or subcutaneously as necessary with 5% in dextrose or in patients with associated sodium deficit isotonic saline. In most forms of dehydration, that means in the sense deprivation of drinking water being an exception, in the case of serious loss, and the one that needs correction is not the fluid but the electrolytes. Okay, so fluid along with these electrolytes are really very important, especially in cases of diarrhea, then vomiting, such type of conditions. So So we need to provide fluids along with the electrolytes. Hypertonic saline is sometimes used, but with great caution where neurologic effects of hypertonicity predominate. Hypernatremia should be corrected slowly. So in dehydration, the sodium imbalance mainly occurs hypernatremia. Okay, so water is lost. So there will be excess concentration of sodium, that is hypernatremia. So this hypernatremia should be corrected slowly. Not more than half of the water deficit should be corrected in the first 12 to 24 hours. Okay, so the next one is water excess, or we can say that overhydration or water intoxication. Water excess is usually associated with an impairment of water excretion, such as that caused by renal failure or the SIADH. SIADH means syndrome of inappropriate secretion of the antidiuretic hormone. This syndrome has several causes including chest infections and some tumors, particularly small cell carcinoma of the lungs. Excess intake is rarely a cause of water excess, since the healthy adult kidney can excrete water at a rate of up to 2 ml per minute. Patients affected usually present with signs consistent with cerebral overhydration, although if it is of gradual onset over several days, they may be asymptomatic. And in water excess or overhydration, the main sodium imbalance is hyponatremia. Okay, hyponatremia is usually present in water excess. Now we will see in detail about the major electrolytes in our body. So the first one is sodium. Sodium is the major cation of the extracellular fluid. Sodium along with chloride, potassium and water is important in the regulation of osmotic pressure and water balance between intracellular and extracellular fluids. Normal values in between 135 to 147 milliequivalent per liter or millimole per liter. The body of an average 70 kilogram man contains approximately 3000 millimole of sodium. Most of the sodium is freely exchangeable and is extracellular. The sodium concentration is defined as the ratio of sodium to water, not the absolute amounts of either. Laboratory tests for sodium are used mainly to detect disturbances in water balance and body osmolality. The kidneys are the major organs of sodium and water balance. About the control of sodium or the regulation of sodium, the control of sodium by the body is accomplished mainly through the hormones aldosterone and antidiuretic hormone. Okay, so the two main hormones involved in the regulation of sodium and water balance is aldosterone and antidiuretic hormone. So this ADH is released from the pituitary gland in response to signals from the hypothalamus. ADH presence in the distal tubules and collecting ducts of the kidney causes them to become more permeable to the reabsorption of water, therefore concentrating urine. So this ADH is mainly involved in the reabsorption of water. This aldosterone affects the distal tubular reabsorption of sodium as opposed to water. Aldosterone is released from the adrenal cortex in response to low sodium, high potassium, low blood volume and angiotensin II. This aldosterone causes the spilling of potassium from the distal tubules into the urine in exchange for sodium reabsorption. So this aldosterone main function is sodium reabsorption. So the two main hormones involved in the regulation of sodium is aldosterone and antidiuretic hormone. Sodium and the extracellular fluid volume. The extracellular fluid volume is dependent upon total body sodium, since sodium is almost entirely restricted to the extracellular fluid, and water intake and loss are regulated to maintain a constant concentration of sodium in the ECF compartment. Normally, 70% of filtered sodium is actively reabsorbed in the proximal tubule, with further reabsorption in the loop of Henle. Less than 5% of the filtered sodium load reaches the distal tubule, where aldosterone can stimulate further sodium reabsorption. Other factors such as natriuretic peptide hormone can also affect sodium reabsorption. This hormone is secreted by the cardiac atria in response to atrial stretch following a rise in atrial pressure associated with the, say, volume expansion. The two major disorders associated with the sodium is hypernatremia and hyponatremia. Hypernatremia means an increase in sodium concentration. This may indicate impaired sodium excretion or dehydration. Next is hyponatremia, which means a decrease in the sodium concentration may reflect overhydration, then abnormal sodium loss or decreased sodium intake. Patients with kidney, heart or pulmonary disease may have difficulty with the sodium and water balance. In adults, changes in sodium concentrations most often reflect changes in water balance, not salt imbalance. Therefore, sodium concentration is often used as an indicator of fluid status rather than salt imbalance. Okay, now we will learn the etiologies or causes behind this disorders affecting the sodium balance. So hyponatremia. Hyponatremia usually related to total body depletion of sodium as in mineralocorticoid deficiencies, sodium wasting renal disease, replacement of fluid loss with non-saline solutions, gastrointestinal losses, renal losses or loss of sodium through the skin, or to dilution of serum sodium as in conditions like cirrhosis, congestive heart failure, nephrosis, renal failure, excess water intake. Then or syndrome of inappropriate antidiuretic hormone secretion. Next is hypernatremia. Usually results from loss of free water or hypertonic fluid or through excessive sodium intake. Usually caused by unreplaced fluid loss through the skin and the gastrointestinal tract. For example, in case of excessive sweating, vomiting, diarrhea. Free water loss is most often associated with diabetes insipidus, but fluid loss can be via the GI tract, renal, skin or respiratory systems. Excess sodium intake can occur through the administration of hypertonic intravenous solutions, mineralocorticoid excess, excessive sodium ingestion, or after administration of drugs high in sodium content, for example, ticarcillin, sodium bicarbonate, etc. So the next major electrolyte is potassium. It is the most abundant intracellular cation. Intracellular fluid potassium averages 141 milliequivalent per liter. Approximately 3500 milliequivalent of potassium is contained in the body of a 70 kilogram adult. Only 10% of body's potassium is extracellular. Normal value is within the range of 3.5 to 5 milliequivalent per liter or millimole per liter. The function of potassium or the role of potassium is in the maintenance of proper electrical conduction in cardiac and skeletal muscles, especially the muscle and nerve excitability. It exerts an influence on the body's water balance, mainly the intracellular volume, and plays a role in acid-base equilibrium. The potassium is regulated by kidneys, mainly through the renal function, then aldosterone, arterial pH, insulin, potassium intake, and sodium delivery to distal tubules. The serum potassium concentration is not an adequate measure of the total body potassium because most of the body's potassium is intracellular. Fortunately, the clinical signs and symptoms of potassium deficiency, which includes malaise, confusion, dizziness, ECG changes, muscle weakness and pain, correlate well with serum concentrations. The serum potassium concentration is buffered by the body and may be normal despite total body potassium loss. Potassium depletion causes a shift of intracellular potassium to the extracellular fluid to maintain potassium concentrations. There is approximately a 100 milliequivalent total body potassium deficit when the serum potassium concentration decreases by 0.3 milliequivalent per liter. This may result in misinterpretation of serum potassium concentrations as they relate to total body potassium. The disorders associated with the potassium include hypokalemia and hyperkalemia. So hypokalemia means serum potassium less than 3.5 milliequivalent per liter. The most ICUs prefer to keep patients at 4 milliequivalent per liter or greater if possible. Signs and symptoms of hypokalemia include weakness, cramps, cardiac arrhythmias, which involves ST depression, QT prolongation, flat T wave, U wave, etc. If severe hypokalemia, which means serum potassium less than 2 milliequivalent per liter, flaccid paralysis can occur. Hypokalemia is usually caused by low dietary intake or unreplaced fluid loss from the GI tract and urine and can be seen after excessive vomiting and loop diuretic use respectively. The kidneys are responsible for approximately 90% of the daily potassium loss. Other losses occur mainly through the GI system. Even in states of no potassium intake, the kidneys still excrete up to 20 milliequivalent of potassium daily. Therefore, prolonged periods of potassium deprivation can result in hypokalemia. Now let's see the etiologies associated with the hypokalemia. Inadequate intake, it's usually rare, kidneys can usually adapt. Then increased losses, mainly through GI fluid losses, for example diarrhea, fistula drainages. Then hypomagnesemia, medications such as diuretics, amphotericin B, mineralocorticoid excess, penicillins. Then polyuria in case of diabetes insipidus. Then renal potassium excretion in case of distal and proximal renal tubular acidosis. Then diabetic ketoacidosis. Then increased requirements. These increased requirements are usually needed in building of new muscle or tissues, which is known as the refeeding syndrome. Then extracellular to intracellular shift. For example, medications such as beta-adrenergic agonist including albuterol, sodium bicarbonate or other alkalizing agents, then insulin. Then acute alkalemia, hypothermia, then pentobarbital or thiopentol. Now moving on to the treatment options of hypokalemia. First of all, we should treat or reduce the potential etiologies for hypokalemia if possible. Ensure hypokalemia is not at least partially attributable to hypomagnesemia. The estimated deficit should be replaced over 1 to 3 days by giving boluses and increasing the potassium content in intravenous fluids and parenteral or enteral nutrition solutions. And next treatment option is enteral or oral potassium supplement. It is a preferred and safer route of delivery because of the time of absorption and feed-forward regulation of potassium homeostasis. Then short-term infusions of potassium chloride or potassium phosphate should be given only by central vein. Potassium chloride can be given at 20 milliequivalent per hour if the patient has continuous electrocardiography monitoring in the ICU. 10 milliequivalent per hour is safest if the patient is asymptomatic or not in the ICU. Potassium chloride comes pre-packaged as 20 and 40 milliequivalent units in sterile water for injection. Hyperkalemia, which means serum potassium greater than 5.2 milliequivalent per liter, although usually not a significant problem until serum potassium approaches 6 milliequivalent per liter. Hyperkalemia most commonly results from decreased renal elimination, excessive intake, or from cellular breakdown such as tissue damage, hemolysis, burns, infections. Metabolic acidosis may also result in a shift of potassium extracellularly as hydrogen ions move into cells and are exchanged for potassium and sodium ions. So this hyperkalemia can be noted in metabolic acidosis states. This is due to extensive potassium release from the cells, but can also be noted in insulin deficiency, diabetic ketoacidosis, beta blocker use, or following cell death in chemotherapy where intracellular stores are released. Decreased potassium excretion from the kidneys, for example in acute or chronic kidney disease, then aldosterone deficiency or aldosterone resistance can also cause increased potassium levels. Signs and symptoms of hyperkalemia include peaked and tender T waves on ECG, then symptoms similar to those of hypokalemia, which includes weakness, paralysis, etc. So in this slide, I have summarized the etiologies behind hyperkalemia. So first one is drugs, which includes potassium sparing diuretics such as spironolactone, amiloride, triamtrene, then angiotensin converting enzyme inhibitors, angiotensin receptor blockers, NSAIDs, heparin, trimethoprim, octreotide. The next etiology is excessive intake, usually in combination with a compromised renal function. Be sure to examine all intravenous fluids, enteral and parenteral regimens. Then penicillin G. Penicillin G contains 1.7 milliequivalent of potassium per million units. Then packed red blood cells. Potassium content is 7.5 to 13 milliequivalent per liter. Then renal dysfunction, as in case of chronic kidney disease, then acute kidney injury. Then hypoaldosteronism, tissue catabolism, such as in cases of chemotherapy, rhabdomyolysis, severe acidemia, then elderly patients. Now the treatment options for hyperkalemia. Calcium gluconate 10%, 1 to 2 gram intravenous slow push, especially if ECG changes, to stabilize the myocardium. Then regular human insulin 10 units intravenously plus or minus 50 gram of dextrose intravenously results in only temporary redistribution. Then sodium bicarbonate 50 to 100 milliequivalent intravenously, especially if acidemic. It results only in temporary redistribution. Then sodium polystyrene sulfonate can be given. It acts as a potassium binder. 25 to 50 gram. Intragastric administration preferred. It increases the potassium elimination. Albuterol. It results in only temporary redistribution. Loop diuretics. Loop diuretics mainly cause hypokalemia. That means it increases the potassium elimination. Then hemodialysis. It increases the potassium elimination. So in this slide, I have included the drugs known to cause hypokalemia as well as hyperkalemia. So examples of drugs known to cause hypokalemia include amphotericin, aspirin, corticosteroids, diuretics, gentamicin, glucose, insulin, laxatives, penicillin G, sodium salt. Okay, then piperacillin, tazobactam, salicylates, sodium bicarbonate, sodium chloride, terbutalin, etc. Then examples of drugs known to cause hyperkalemia, mainly angiotensin converting enzyme inhibitors, antineoplastic agents such as cyclophosphamide, vincristine, NSAIDs, beta blockers, then cyclosporin, digoxin in acute overdose, then diuretics, especially potassium sparing diuretics, heparin, isoniazid, lithium, penicillin, potassium salt, then potassium supplements, tetracycline, etc. Moving on to the next electrolyte, which is calcium. It plays an important role in nerve impulse transmission, muscle contraction, pancreatic insulin release, and hydrogen ion release from the stomach, acts as a cofactor for some enzyme reactions and blood coagulation, and most importantly for the bone and tooth structural integrity. Normal total calcium values are 8.8 to 10.3 milligram per dl or 2.20 to 2.56 millimole per liter. Kidney is the primary route of elimination. Then one important point is that magnesium status can influence calcium homeostasis. Hypomagnesemia results in end-organ resistance to parathyroid hormone. Hypomagnesemia may impair parathyroid hormone secretion. Hypocalcemia will correct within 2 days after hypomagnesemia is corrected. The body of an average man contains about 1 kilogram of calcium and 99% of this is bound within bone. Calcium is present in serum bound mainly to the albumin component of protein 46%, complexed with citrate and phosphate 7% and as free ions 47%. Only the free ions of calcium are physiologically active. Calcium metabolism is regulated by 1,25 dihydroxycholecalciferol, which is vitamin D, which when serum calcium is low is secreted to promote gastrointestinal absorption of calcium, and by parathyroid hormone, which is inhibited by increased serum concentrations of calcium ions. So this calcium release or the calcium regulation is mainly by the action of vitamin D, which is also known as 1,25 dihydrocholecalciferol, then parathyroid hormone as well as calcitonin. This parathyroid hormone is secreted in response to low calcium concentrations and increases serum calcium by actions on osteoclasts, kidney and gut. So the function of this parathyroid hormone is to increase the serum calcium, and the function of this calcitonin is to decrease the serum calcium levels. Now we will see the disorders associated with the calcium. First one is hypocalcemia. Corrected serum total calcium less than 8.5 milligram per deciliter in non-ICU patients. Then ionized serum calcium concentration less than 1.12 millimole per liter. Hypocalcemia usually implies a deficiency in either the production or response to parathyroid hormone or vitamin D. Parathyroid hormone abnormalities include hypoparathyroidism, pseudohypoparathyroidism or hypomagnesemia. Vitamin D abnormalities can be caused by decreased nutritional intake, decreased absorption of vitamin D, a decrease in production or an increase in metabolism. So here you can see the etiologies associated with the hypocalcemia. That is a critical illness, then continuous renal replacement therapy, massive blood transfusion, hypomagnesemia, hyperphosphatemia. That is, there is a relationship between calcium and phosphorus and the relationship is inverse. Okay, so if there is an increase in calcium, there will be decrease in phosphorus. Okay, so in between this calcium and phosphorus, there is an inverse relationship. Okay, so for this hypocalcemia, the etiology is hyperphosphatemia. Okay. Then pancreatitis, drugs such as amphotericin B, cisplatin, cyclosporin, fuscarnet, bisphosphonates, loop diuretics, then malabsorption, hypoparathyroidism, chronic kidney injury or acute kidney injury, vitamin D deficiency, severe alkalemia. Then the signs and symptoms of hypocalcemia include tingling, paresthesias, hyperactive deep tendon reflexes, Vostek and Trousseau signs. This Vostek and Trousseau signs means these are specific for hypocalcemia and hypomagnesemia. So Vostek sign means twitching of facial muscles in response to tapping over the facial nerve. And Trousseau signs means carpopedal spasm induced by pressure applied to the arm by an inflated sphygmomanometer cuff. Then prolonged QT interval. Then treatment is mainly the supplementation of calcium. Okay, either it can be oral or through the intravenous route. So calcium supplements can be given for the management of hypocalcemia. Several different kinds of calcium compounds are used in calcium supplements. Each compound contains varying amounts of calcium, which is known as the or referred to as the elemental calcium. Common calcium supplements may be labeled as calcium carbonate, which contains the highest percentage of elemental calcium, which is about 40%. Then calcium citrate contains 21% of elemental calcium. Calcium gluconate contains 9% and calcium lactate contains 13% of elemental calcium. Now hypercalcemia, that is the corrected serum calcium greater than 10.5 milligram per deciliter or ionized calcium greater than 1.32 millimole per liter. Signs and symptoms are more evident when total serum calcium of 12 milligram per dl or greater or ionized calcium of 1.5 millimole per liter or greater. This hypercalcemia is an increased calcium concentration and it is usually associated with a malignancy or metastatic diseases. Other causes include hyperparathyroidism, Paget disease, milk alkali syndrome, granulomatous disorders, thiazide diuretics, excessive calcium intake or vitamin D intoxication. Okay, so here you can see the summary of etiologies or causes behind this hypercalcemia. Immobilization, chronic critical illness associated with a metabolic bone disease, then excessive calcium intake, hyperparathyroidism, granulomatous diseases such as tuberculosis, sarcoidosis, then malignancy, drugs such as thiazide diuretics, vitamin D intoxication, then dehydration. Signs and symptoms of hypercalcemia include mental status changes, polyuria, shortened QT interval bradycardia, atrioventricular block. Treatment options. Mobilize the patient if possible, then discontinue calcium from the parenteral nutrition solution. Intravenous fluids with 0.9% sodium chloride if dehydrated at 200 to 300 ml per hour for 48 hours or until rehydrated with or without furosemide 40 to 80 mg intravenously every 12 hours. Then calcitonin 4 units per kilogram intramuscularly every 12 hours can be increased to 8 units per kilogram every 12 hours as needed. Pamidronate 90 mg intravenously once for acute hypercalcemia not related to etiologies 1 and 2. Etiologies we have discussed in the previous slide. Etiologies 1 and 2 includes immobilization and chronic critical illness associated with a metabolic bone disease. Then this pamidronate 30 mg intravenously daily for 3 days if hypercalcemia caused by etiologies 1 and 2. Next treatment option is parathyroidectomy for patients with primary hyperparathyroidism. Then prednisone 40 mg per day and greater for 10 days for patients with granulomatous diseases, for example sarcoidosis, tuberculosis, etc. So the next electrolyte is phosphate. Phosphate is a major intracellular anion and is the source of phosphate for adenosine triphosphate and phospholipid synthesis. Serum calcium and phosphate are influenced by many of the same factors. It is useful to consider calcium and phosphate together when interpreting lab results. As I have already mentioned, there is an inverse relationship between calcium and phosphate. Normal phosphate values are 2.5 to 5 mg per dl or 0.80 to 1.60 millimole per liter. Serum concentration can be influenced by parathyroid hormone. That is, increased parathyroid hormone leads to increased urinary excretion of phosphorus, and alkalemia can decrease serum phosphorus concentration. Kidney is the primary route of elimination. So the disorders associated with the phosphate level includes hypophosphatemia and hyperphosphatemia. So this hypophosphatemia means serum phosphorus less than 2.5 to 3 mg per dl, severe hypophosphatemia less than 1 to 1.5 mg per deciliter. The extracellular fluid concentration of phosphate is influenced by parathyroid hormone, intestinal absorption, renal function, nutrition and bone metabolism. Hypophosphatemia can occur in malnutrition, especially when anabolism is induced after administration of aluminum containing antacids or calcium acetate, in chronic alcoholics and in septic patients. So here you can see the etiologies behind hypophosphatemia: alcoholism, malnutrition or refeeding syndrome, then critical illness especially trauma, thermal injury, diabetic ketoacidosis, hepatic resection, drugs such as insulin, catecholamines, antacids, sucralfate, calcium, alkalemia, malabsorption, especially in the case of chronic diarrhea, hyperparathyroidism, then cancer. Signs and symptoms include weakness, paresthesias, severe depletion can lead to congestive cardiomyopathy, cardiac arrest, seizures, coma, respiratory arrest, rhabdomyolysis. Then hyperphosphatemia. Here, serum phosphorus concentration greater than 5 mg per dl, usually not clinically relevant until serum phosphorus is greater than 6 mg per dl. So here you can see the etiologies associated with hyperphosphatemia, that is renal failure, immobility, chronic critical illness associated with the metabolic bone disease, excessive phosphorus intake, vitamin D toxicity, tumor lysis syndrome, then hypoparathyroidism. Signs and symptoms include hypocalcemia and metastatic calcification. Example, neuromuscular irritability, prolonged QT interval, tetany, etc. Usually does not occur until the serum calcium phosphorus product approaches 55 or greater. Now let's see the treatment options for hyperphosphatemia. So the first one is reduce the phosphorus intake. Next is the phosphate binders. And here you can see the examples for phosphate binders, which includes calcium carbonate, calcium acetate, sevelamer, lanthanum, and their available strength, phosphorus binding capacity, and the recommended empiric initial dose. Now magnesium. Magnesium is the second most abundant intracellular and extracellular cation. It is an activator of numerous enzyme systems that control carbohydrate, fat, and electrolyte metabolism, protein synthesis, nerve conduction, muscular contractility, as well as membrane transport and integrity. Normal values are 1.6 to 2.4 milliequivalent per liter or 0.80 to 1.20 millimole per liter. Kidney is the primary route of elimination, around 70% reabsorbed in the ascending loop of Henle. Losses can be extensive with severe diarrhea or body fluid drainages. Magnesium depletion can influence potassium and calcium homeostasis. The disorders associated with the magnesium levels include hypomagnesemia and hypermagnesemia. So hypomagnesemia means although the lower limit of normal for serum magnesium concentrations is 1.8 mg per dl or 1.5 milliequivalent per liter, most clinicians define significant hypomagnesemia as 1.5 mg per dl or 1.3 milliequivalent per liter or less. Many ICUs have a target serum magnesium concentration greater than 2 mg per dl. Hypomagnesemia is found more often than hypermagnesemia. Serum concentrations of magnesium may be slightly, falsely lowered in the presence of significant hypoalbuminemia. The signs and symptoms include muscle weakness, cramping, paresthesias, Vostek and Rousseau signs, then tetany, QT prolongation, hypokalemia, then hypocalcemia. Etiologies. First of all, gastrointestinal losses, especially diarrhea, average stool loss of about 6 milliequivalent per liter up to 10 to 12 milliequivalent per liter or greater for secretory diarrheal losses. Then alcohol, increased renal excretion, impaired absorption, poor nutritional status of the patients who abuse alcohol. The next causes sepsis or critical illness that will lead to increased urinary excretion of magnesium. Then pancreatitis, partially attributable to calcium magnesium soap formation in the peritoneum. Then thermal injury or traumatic brain injury, there will be increased urinary excretion of magnesium and polyuria. Drugs causing hypomagnesemia include loop and thiazide diuretics, proton pump inhibitors, aminoglycoside antibiotics, amphotericin B, chemotherapeutic drugs such as cisplatin, calcineurin inhibitors, antibodies that bind to epidermal growth factor receptors. Examples: cetuximab, matuzumab, then panitumab, then laxative abuse. Now, the treatment options for hypomagnesemia. First of all, treat the etiology if possible. Then successful treatment of hypomagnesemia usually takes 3 to 5 days of intravenous therapy. Intramuscular magnesium therapy for replacement therapy is inadvisable because of the limit on volume per injection site with respect to dosage requirements and tissue irritation. Then the treatment options include intravenous magnesium sulfate as well as oral magnesium. So intravenous magnesium sulfate 32 to 48 milliequivalent per day, that is approximately 4 to 6 gram per day, suggested to be sufficient to maintain serum magnesium within 2 to 2.5 milligram per deciliter for most magnesium deficient patients. Then oral magnesium, difficult to successfully accomplish in critically ill patients because of the adverse gastrointestinal effects of oral magnesium, for example diarrhea, and the high elemental magnesium doses required to achieve the repletion. The lower the elemental magnesium content, the more tolerable the oral product. And here you can see the common oral magnesium products, which includes the magnesium oxide, magnesium gluconate, then magnesium chloride, and their available strength, elemental magnesium content, and their usual dosing. So regarding their percentage elemental magnesium content, the magnesium oxide form contains the highest percentage of elemental magnesium, which is about 60, followed by carbonate, hydroxide, citrate, lactate, chloride, sulfate, and gluconate forms. Hypermagnesemia. Here, serum magnesium concentration greater than 2.4 mg per dl. Patients usually do not experience symptoms until the serum magnesium concentration exceeds about 4 mg per dl. Signs and symptoms of hypermagnesemia include bradycardia, flushing, sweating, nausea and vomiting, decreased calcium level, decreased deep tendon reflexes, flaccid paralysis, increased pulse rate and QRS intervals, respiratory distress and asystole. Etiologies. Hypermagnesemia is most commonly caused by increased magnesium intake in the setting of renal insufficiency. Other causes include excess magnesium intake, hepatitis and Addison's disease, excessive dosing of magnesium and acids, post-cathartic use, for example magnesium citrate. To develop hypermagnesemia, these events usually occur together with a renal impairment. Then treatment options. Remove source of magnesium intake. Intermittent slow bolus doses of calcium gluconate 2 gram over 5 to 10 minutes until severe symptoms abate or reduce. The effect of calcium is transient and repeat therapy may be needed as frequently as every hour. Then ventilate the patient if necessary. And the last treatment option is hemodialysis. Chloride. It is a major anion of the extracellular fluid and is important in the maintenance of acid-base balance. Alterations in the serum chloride concentration are rarely a primary indicator of major medical problems. Chloride itself is not of primary diagnostic significance. It is usually measured to confirm the serum sodium concentration. The relationship among sodium, chloride and bicarbonate is described by the following. Cl minus plus HCO3 minus plus R is equal to Na plus, where R is the anion gap. Anion gap means it is the difference between the cations and the anions. The normal value for chloride is 95 to 105 milliequivalent per liter or millimole per liter. Now the two disorders associated with the chloride levels are hypochloremia and hyperchloremia. Hypochloremia is a decreased chloride concentration and it is often accompanied by metabolic alkalosis or acidosis caused by organic or other acids. Other causes include chronic renal failure, adrenal insufficiency, fasting, prolonged diarrhea, severe vomiting and diuretic therapy. Then hyperchloremia is an increased chloride concentration that may indicate hyperchloremic metabolic acidosis. Hyperchloremia in the absence of metabolic acidosis is unusual because chloride retention is often accompanied by sodium and water retention. Other causes include acute renal failure, dehydration, and excess chloride administration. And the next one is bicarbonate bar carbon dioxide content. The carbon dioxide content represents the sum of the bicarbonate concentration and the concentration of carbon dioxide dissolved in the serum. The bicarbonate bar carbon dioxide system is the most important buffering system to maintain pH within the physiological limits. Most disturbances of acid-base balance can be considered in terms of this system. Bicarbonate levels shift in acid-base disturbances. There is an increase in bicarbonate levels in primary metabolic alkalosis and it acts as compensation in primary respiratory acidosis. Bicarbonate falls in both primary metabolic acidosis and also decreases in response to primary respiratory alkalosis. Normal values are 22 to 28 milliequivalent per liter or millimole per liter. The relationship among this system is defined as follows. Okay, so here you can see the bicarbonate ions. These bicarbonate ions bind with hydrogen ions to form carbonic acid, that is H2CO3. Clinically, the serum bicarbonate concentration is measured because acid-base balance can be inferred if the patient has normal pulmonary function. CO2, that is carbon dioxide plus water by the action of carbonic anhydrase will give H2CO3, that is carbonic acid, which is a reversible reaction, okay, which will further dissociates to form HCO3 minus and a H plus, that is bicarbonate ion and a hydrogen ion. Now the disorders associated with the bicarbonate levels, which includes hypobicarbonatemia and hyperbicarbonatemia. Hypobicarbonatemia usually caused by metabolic acidosis, renal failure, hyperventilation, severe diarrhea, drainage of intestinal fluid, and by drugs such as acetazolamide. Then toxicity caused by salicylates, methanol, and ethylene glycol can also decrease the bicarbonate levels. Then hyperbicarbonatemia means excess level of bicarbonate. It is usually caused by alkalosis, hypoventilation, pulmonary disease, persistent vomiting, excess bicarbonate intake with a poor renal function and diuretics. So with this slide we have completed this topic. If you have any questions or any doubts, you can share it in the comment section. So thank you for watching this video. Have a good day.